Welcome to the perioperative medicine session. And this is a session that has been chosen to be one of the 10 sessions representing perioperative medicine. So the fact that you come here, that shows that this is a very, very special session, and welcome. As you can see here, we are going to talk about the future of perioperative medicine, opportunities and challenges. And you have 3 speakers. I'm going to lead off. And then we're going to invite Dr. Ehrman and as well as Dr. Stier to deliver the next 2 presentations. My name is TJ Gan. I am currently the head of anesthesia at MD Anderson in the Department of Anesthesia, Critical Care and Pain Medicine. And I'm going to kick off to give you a bit of background about perioperative medicine, what I think the future is, and would love to engage you. We're going to have Q&As after this, and we'd love to engage you for your discussion, because we are all experts, not just 3 of us. We are all experts in perioperative medicine. So I'm going to give you my perspective. I'd love to hear from your perspective. These are my disclosure. So why are we interested in this topic? Well, the reason is we are doing a lot of surgery, right? And the population is increasing, and it's estimated on average a person get about 9 procedures throughout his whole lifetime. You can count a number of surgery. If you are actually below that, great job. Just trying to escape it. Don't volunteer for surgery if I were you. But if you happen to need surgery, that is where I think we need to do a better job. Why? Because perioperative death or postoperative death is the 3rd leading cause of mortality. Would you believe that? After ischemic heart disease, we all know ischemic heart disease, stroke is a major killer, but postoperative death, really? The 3rd most common cause? So we really have some serious issue to deal with. And where do the deaths occur? 3/4 of the patients who died in the hospital were not admitted to an ICU. You spend all this money in ICU with all the resources, and yet when the patient needs it, they are not there. They die, not in the ICU. And about half of all the adverse events in a hospitalized patient occur on the general ward. On the general ward. Imagine that. People die without going to ICU, and that's responsible for about 85% of postoperative mortality. Now, you can say that, well, anesthesiologists, we do a good job to prevent intraoperative anesthetic-related mortality. And you are right. Anesthetic mortality has gone down substantially. If you look at these statistics, in 1940, about 1 in 1,000 of patients died directly from anesthetic cause. Every 3 decades, we reduce the anesthetic-related mortality by about 10-fold. So 1970, 1 in the 10,000. Roll for another 30 years, 2000 is 1 in 100,000. So we are now about 130, 140,000. So we have done a good job intraoperatively, but postoperatively is still a major problem, in particular morbidity. If you look at statistics here, postoperative morbidity is about 14 times the rate of mortality. And what does it mean? It means patients stayed longer in the hospital, patients suffered, increased healthcare costs, and that is where I think we need to focus in this area, and that is what perioperative medicine is about. And perioperative medicine is about how to lead. Now, we have always been leading in the perioperative area. So this editorial that was written almost more than 10 years ago, the role of anesthesiologists as perioperative physicians, because this is a multidisciplinary subspecialty, but we are well positioned to lead in this field of perioperative medicine, because we have the skill, we have the training, we have the experience, and if you don't lead, somebody else is going to lead it. So you might as well lead it. Now, we have shown in enhanced recovery, where we lead in enhanced recovery, multimodal, multi-specialty team have done a good job. All of you recognize that enhanced recovery has improved post-operative care, right? Once you have enhanced recovery protocol, you have shortened length of stay, reduced complications. And we have been recognized as leader working with surgeons and other multidisciplinary team. And we have also led in other areas, OR management, critical care. We have done preoperative clinic, acute pain service, resuscitation. So I think we need to fill in this role what I call the acute care coordinator. Because again, all the leadership role that we have done in the hospital. Now, many of you should remember that in the perhaps 70s and 80s, when you started going to the preoperative evaluation clinic, at that time we went in reluctantly, but don't you think that we did the right decision by going and manage a pre-op screening clinic, because we have shown able to reduce cancellation, reduce length of stay, reduce mortality having pre-op screening clinic. But there are a lot of other areas that we can potentially reduce risk. These are some of the predictors of perioperative risk, and some of them you can't control, but some of them you can, right? There are some modifiable risk that we can control. Some of them are acquired, like anemia, nutrition, chronic pain, and others are lifestyle, because patients don't go for surgery that often. As I said, average 9 times a year in their lifetime, and often much less. And that is where you can potentially modify some of their bad habits: smoking, alcohol, nutrition, mental health, physical activity. And there's opportunities to improve their lifestyle in the much longer term, not just that episode of surgery. So the areas that we have potential opportunity to try to target are what I call optimization of the patients, whether it's their comorbidity, nutritional status, hemoglobin, prehabilitation, cardiopulmonary fitness, respiratory training, and all these have been shown to be predictor of post-operative complications. And we know that, for example, poor nutrition increase risk of mortality, it increased chances of complications, but despite that, only 1 in 5 hospitals have formal nutrition screening processes. And although 3 or 4 surgeons believe that perioperative nutrition will reduce complication, and it's clear if you look at statistics that every dollar you spend in nutrition, you can save $52 in hospital costs. When you talk about our CEO about return on investment, who would not invest $1 and get $52 back, right? But yet only 1 in 5 patients receive any pre-op nutrition intervention. So there's a disconnect there. Now we know that anemia is another common complications, even prevalence preoperatively, and the prevalence is, depending on the type of surgery, can be up to 40–50%. And we know that it is an independent factor that increases mortality. And there's been studies showing that if you have no anemia, no comorbidities, your 30 days morbidity is pretty stable, 4 or 5%. But once you have anemia, that goes up. Depending on the type of surgery, regardless of type of surgery, it's about 13–14%. But if you have anemia plus other comorbidity, that goes up even higher. So anemia is something that we should focus on, and I know that some of you have anemia clinic in your hospital. Who of you have anemia clinic in the pre-op and managing anemia? Relatively few. So this is a great opportunity to have that service to correct anemia with irons, IV iron, oral iron, depending on how long that you have. And that can potentially improve outcome. Now, frailty is another one. We know that as patients get older, whether you like it or not, you become frail, right? And it is a distinct health state that related to the aging process. You can't escape it. 10% of over 65 has frailty. The over 85, 50%, 1 in 2, come for surgery has frailty. And that means cognitive decline, morbidity, higher complications. And we all know what frailty can result. Increased hospitalization, increased complications, increased healthcare costs, and there are a number of scoring systems you can use, but still, in general, most hospitals don't really focus on assessing frailty. How can we triage patients with frailty so that perhaps we can get them in a better state? A process what we call prehabilitation, which is trying to enhance the functional capacity of an individual so that the patient can withstand a stressful event, because surgery is a very stressful event. And in fact, it has been akin to running a marathon, and we normally take months to prepare for a marathon, right? But often patients don't have the luxury of months to prepare themselves, not even weeks, sometimes days. So that is, we have the time interval between diagnosis and surgery. That is a potential time to trying to have a prehabilitation program where the patient can get functionally more physiologically robust. And there have been studies, in this one in particular, multi-center, multi-country studies that show that 4-week supervised multimodal prehabilitation program looking at exercise, nutrition, psychological support, as well as smoking cessation, and found that if you were to go through this program, your incidence of complications are significantly lower. And when they look at functional capacity, whether it's 6 minutes walk test, exercise, these patients have much better functional capacity and translate to better post-operative outcome. Another area that are starting to be recognized is post-operative delirium. We know that how much it can interfere with recovery. And the incidence of delirium is very, very common, especially in elderly population. Increased complication, increased length of stay, increased healthcare costs. And yet, we often don't monitor them. Maybe by a show of hand, anyone do delirium scoring before surgery? Almost none, right? Or in fact, Dr. Steele is going to talk to us. And that is where I think there is tremendous opportunity to improve. In fact, there was a study recently that looked at, can we prehabilitate cognitive function? So enroll this group of patients over 60, and one group got a participate in a 10-hour electronic tablet-based cognitive exercise targeting memory, speed, attention, flexibility, and problem solving. And they found that that group actually did better, have lower incidence of delirium. Interesting, small study, but interesting outcome. Another area that I think that we haven't really even touched is having us as anesthesiologists, as a public health physician. We can impact more than patient coming for surgery. And there's historical aspect to it, right? And if you look at John Snow, anesthesiologists who recognized the cause of cholera as public health physicians. So we could potentially step up to that role. And nowadays, with innovation and technology, there is another potential opportunities, advanced monitoring system with neuromonitoring, cardiac monitoring, potentially can improve outcome, and also post-operative physiological monitoring. Now there's this concept now to see how can we better prepare the patient through the perioperative journey. Some places are starting to use health coach to take that patient through that surgical journey. At MD Anderson, we have a patient navigator where the patient can call when they have questions, because often patients are reluctant or afraid of asking physicians, asking nurses. So this is someone that can take them through that perioperative journey. Now, as you know, ASA had formed a Center for Perioperative Medicine, and the vision is really trying to improve patient care and where we can contribute to that process so that we can then have a team to try to manage this patient. We had a summit yesterday where we had organizations nationally as well as surgical organizations participated. It was a great success, and we are starting to engage other specialty in this effort of perioperative medicine, how to improve post-operative care. So these are some of the potential opportunities. Expand the role of preoperative evaluation clinic, incorporate rehabilitation, coordination of perioperative care, and we lead that in a multidisciplinary teams. With enhanced recovery, we know that evidence-based care can be adopted much more readily. Demonstrate outcome and value. I think that is also another important. How can that save us money? How can it save healthcare resource? Very importantly, and my second speaker in a talk on that, is how do you educate the next generation? Because we've got to prepare our workforce, our anesthesiologists, so that they can be competent perioperative physicians, because current training lacks training in perioperative medicine. I'm going to leave Dr. Ehrman to talk about that. Public health, we talked about, maximize technology. So I think there are lots of opportunity. Obviously, they come with challenges, and we can discuss some of the opportunity and challenges during the discussion. With that, I'm going to invite my second speaker, Dr. Ehrman, and Dr. Ehrman is chair of anesthesia from Ohio. He always remind me, I got to say, the Ohio State University. And Dr. Ehrman is going to talk to us on the education piece because Dr. Ehrman participated in this subcommittee that we spent over 2 years trying to come up with a curriculum. How do we educate the next cohort of our perioperative physicians? So I'm going to go back here. Thank you very much for attention. All yours, Dr. Ehrman.
Oh, good. Thanks, TJ. Excellent. All right, so what I would like to do in the next 15 minutes is to cover perioperative education-related activities and what we have accomplished so far. And I think we made a lot of progress, as you will see. Let's see, let's figure this out. So I'll give you a little bit of a background, how it all started, how a few of us got together thinking about sort of, as TJ said, sort of the next generation of anesthesiologists and others who work with us. Again, looking at the principles that he so thoroughly outlined in his presentation, recent accomplishments, publications, other things, and then future directions. And those are my disclosures that are not directly relevant. So once we kind of looked at the landscape of perioperative medicine education, and again, it's important to separate residency and then fellowship training for the purposes of what we're trying to accomplish here. Clearly, there's overlap. Only a handful of active periop medicine fellowships. I ran one at my former institution before I transitioned to OSU. Definitely lack of standardization, curricula, who is learning what, who is teaching what, and really a lot of variability, curriculum content, areas that are emphasized, and some of them, and I'll show you, they call them periop medicine fellowships, yet it's sort of a combination of many different things. And then how these fellowships are structured in terms of clinical, non-clinical responsibilities, focus on clinical work versus research and other non-clinical activities, and how they're funded as well. Usually 1-year fellowships in duration, and then they're all non-ACGME internally funded in a kind of variety of different ways. So that was sort of the landscape, when we looked at it, I don't know, 7, 8 years ago. We put together this figure, just kind of, again, identifying institutions who had an active periop medicine fellowship And that, if you really think about it, that's quite a few. Not all of them had fellows and, at one time, but but having said that, there's quite a few large academic institutions who at least were thinking about this. They thought it was a good idea, and they did have a functioning periop medicine fellowship. We also tried to learn from existing perioperative medicine training. One, obviously, a well-known program is run by UCL London, and I had the privilege of visiting them, I don't know, about 7 or 8 years ago, and hosted one of their master's students, if you will, getting a master's in perioperative medicine, which is what you get, that degree. Very flexible program. You can complete it in as few as 1 year and maybe as many as 5 years. And a lot of it is virtual. It's sort of kind of a combination, but mostly a lot of it is very flexible. And so that's an ongoing program, and we thought, well, we have a lot to learn, right, from people who kind of put something like this together. It's all online. It was all virtual at the time. So we got together. That's sort of how the story goes. In 2018 in San Francisco, one of the ASA meetings, you see, obviously, myself, Dr. Gann, you see Manti Maitan, you see Carol Pete, and then several other people, some from the UK, who, again, have a lot of experience with this. And we sort of had some initial conversations about where do we want to go with this idea. And, of course, a lot of these discussions, I'm skipping quite a few years, culminated into CP Med idea. But as Dr. Gantz said, one of the main pillars is education, one of the main areas of focus. And I kind of highlighted two of them, education work group, as well as the ABA, ACGME work group. So if you really think about it, 50% of priorities, half of the priorities for CPMED are somehow focused on education. So really a big area of focus for the ASA. I also like to, always talk about this. So that's sort of us kind of discussing it, thinking about, where do we want to go with this? We did want to forge our own path, and at the same time being aligned with, goals for education and ASA priorities as well. And at least in my mind, some of the guidance for me came from, IHI, Institute for Healthcare Improvement, kind of structuring these fellowships. And what are sort of some of the basic tenets, basic principles that should be taught and should somehow be incorporated into the curriculum in terms of making healthcare safe, timely, effective, efficient, equitable, and patient-centered. And of course, it being evidence-based is a big part of that. So again, we formed, ASA formed a ad hoc committee at the time on perioperative medicine. Dr. Gann led this ad hoc committee. There were several of us who kind of put the initial sort of outline and some of the things that we wanted to accomplish in terms of curriculum. Look at existing, as you're all familiar with, ACGME requirements and things like that. And then really come up with what it is that we want to teach, what it is that we want to include in this curriculum template, if you will. And thinking about core versus aspirational components of the curriculum, what we believe is absolutely necessary and should definitely be taught versus some things that probably is a good idea, but were more of an aspirational in nature. And of course, the idea was to put something in writing, have a kind of some sort of deliverable that could be disseminated, right? At the end of the day, this is what it's all about, and getting all the right stakeholders involved. So I believe we accomplished pretty much all of it. I mean, there's still work to be done, but we made a lot of progress. And again, using ACGME curriculum template, sort of these are familiar to many of you in terms of the competency-based goals, right? And what else do we want to recommend in terms of didactics, in terms of how it's structured, and what kind of additional experiences we want our periop medicine fellows, but also our residents and others learning perioperative medicine in terms of administrative experiences, leadership experiences, and research experiences. So it was sort of an all-encompassing idea. And we came up with the proposed focus areas. Again, our focus, just to be clear, was on a fellowship training. So a separate, whatever it might be, 1 year of periop medicine training. You know, we're not talking about residency, even though obviously the two are, there's definitely overlap, right? And the areas that we identified, sort of preoperative, intraoperative, postoperative phases of care needed to be covered. Medical knowledge, a lot of the things that Dr. Gann already mentioned, anemia optimization, you know, geriatric care, and all of these other things. Technical skills, things that perhaps our residents are introduced, anesthesiology residents are introduced to, but not necessarily, this training is not necessarily emphasized. Of course, this is evolving, things like POCUS and whatnot. Professional leadership and administrative care coordination, and then things like, you know, the business of medicine, right? The finances, the sort of the billing, how to set up a pre-op clinic, you know, things like that. And that's really it. This is a paper that I published a long time ago as part of my FAIR grant. It was a different topic, although it's in some ways related, obviously, to perioperative medicine. But, you know, one of the other guiding principles was sort of the framework, right? How do you, you know, sort of go into the very basics. Having done a fellowship in education, this is something that I truly value, sort of taking a step back and thinking about how do we design a curriculum, an intervention? How do we test it to make sure that, first of all, it accomplishes our goals, that it is effective, and, you know, measuring results, right? So those are kind of the, if you look at the sort of 6-step framework that's well established in terms of identifying the problem, what it is that we're trying to accomplish. And it's easier than said, right? I mean, on the surface, it makes sense. We're going to teach perioperative medicine, but really the devil is in the detail. What is the problem, and what it is? What are the actual needs, right? You know, targeted needs assessment, goals and objectives, educational strategies, implementation, evaluation, and feedback, just as important. So that was sort of one of the guiding principles, at least in my mind. Did I go in the wrong direction? Let's see. There you go. So I just want to show you just something else. I'm involved with SPOCI, Society for Perioperative Assessment and Quality Improvement. And again, we're looking at other models. One was UCL London. Another model that, again, evolved over time, and I was part of sort of the initial conceptualization of this fellowship intended for people with some experience in perioperative medicine who want to get some formal training, and kind of just trying to understand how SPOCI did it and just sort of looking at other ideas, if you will. And it's just important to acknowledge this fellowship that's in existence, that is popular. There's a paper that was published, just came out in ANA, again, describing this periop medicine fellowship. And if you're interested, you know, take a look. And ultimately, this one grants a designation of Distinguished Fellow of Perioperative Medicine. This is, you know, you participate in didactics, and there's a project and things like that, and that's been very popular. We also looked at what's out there currently, right? Because it was important for us to engage people who are actually running these fellowships. So UC Irvine was some of the, you know, one of the first institutions to run a periop medicine fellowship. Monty, Brigham and Women's, the one that I ran for many years. And then there are others, and it's interesting. Some are called periop medicine fellowship, but they incorporate many other concepts, like OR management. Like Stanford is focused a lot on that, for example. There's also onco anesthesia fellowship that at MD Anderson, for example. Again, the focus is on periop medicine, but also some focus on anesthesia related to oncologic surgery. And of course, the elements that come up, you know, things like perioperative surgical home, ERAS, and a lot of them are sort of obviously interrelated in many ways. So that was sort of our kind of due diligence, if you will, just thinking about looking at the landscape, as I alluded to earlier. And how do we teach, right? That's sort of going back to, again, kind of the principles, basic tenets of education and designing a curriculum, right? What kind of methodology do we want to recommend, or what works, what doesn't work. And usually it's a combination of things, right? And thinking about retention rates, and there's lectures, there's sort of pre-made videos, lectures, versus things that are more engaging and interactive and things like that. So something to think about. If you think about creating your own curriculum using some of our what we have proposed, I think it's important to think about how do you actually implement, what works, what doesn't. So this was the final outcome. At least one of our main goals is to publish a template. So this just came out in ANA as well. And this is the development of a standardized perioperative medicine fellowship curriculum. Again, the focus is on fellowship training. And so we used a very robust Delphi process. We engaged a lot of people, lots of experts. We had a core group, and then we had a much larger group. We solicited a lot of feedback, several Delphi rounds of discussing the different elements, what should not be included. We came up with almost 300 topics. And really, if you think about it, we divided into 3 categories: medical knowledge, evidence-based knowledge, system-based approaches to optimizing patients, patient care, and that's ethics, patient-centered care, of course, procedural assessment skills, and then professionalism and practice-based learning. So those are sort of the 3 main categories that I outlined on the right-hand side. And I'll just very quickly just show them to you. We're not going to go over that in the interest of time. It's all in this paper. But again, just going through all of these very, very exhaustive lists. So if you're thinking about medical knowledge, right, you got heart failure. Just to give you a taste of kind of very specific topics, system-based topics that we believe is really, really a key part of perioperative medicine training. I'm not saying that that's not covered, a lot of it during residency training, but this is, in my mind, a very different, more thorough, more focused approach with a lot of focus on optimization and thinking about not just short-term, but also long-term outcomes. So, this is system-based, as you can imagine, every single system, neurologic disorders, endocrine, and so on, nutrition and electrolyte balances and things like that, or liver, kidney, and so on. And then getting into, obviously, pain issues and vulnerable populations as well, patients with low health literacy. Again, going back to my AHI, those AHI principles, right? It's really, really important to incorporate things like addressing the needs of vulnerable populations. And then getting into very specific skills, and then and compassion, integrity, and respect for others, so the ethical piece as well. And then finally, getting into professionalism, interpersonal communication skills, systems-based practice, and just as importantly, research being part of the curriculum, practice management, education. So that's really it. Additional activities, again, a lot of it is part of CP Med priorities, and that is, working with, I'm on that group as well that Dr. Gann is leading as well. I'll let him talk about it if we have time, but really working with ABA, trying to incorporate some of these principles into ABA, ACGME curricula, and, MOCA and things like that. So that's work in progress as well. And collaborating with the ABA to identify formal routes to accomplish this, and potentially even some sort of accreditation for this fellowship. Some national recognition would be one of our goals. So that is, again, work in progress. So this is where we are. Again, I did put up a SWOT analysis, because thinking about one question people always ask, well, what do we go with this? Why would somebody do it? Why would someone say, yeah, I want to do this? Clearly, there's precedent. People are doing it. They're interested. There's definitely a lot of strengths, a lot of benefits. There's also some competing priorities for people, as we're all well aware. So a lot of it is about stakeholder engagement. Once we came up with this framework, what's next, right? ASA, ABA, obviously other subspecialty societies, kind of taking it to the next level, and dissemination, of course, and standardization. So that's all I have. And as Dr. Gant said, it's one of the CP Med sessions here, and really, really appreciate your listening. And happy to answer questions. Oh, yeah. Our next and final speaker is Dr. Steer, Gary Steer. I'm going to bring up his lecture. Hopefully, here it is. Yeah.
Thank you.
Yeah.
Yeah. Hey, I want to thank for the invitation to speak today. I'm going to be speaking on a topic that has been my passion for a long time. My title is Getting the C-Suite to Recognize the Effort for Perioperative Medicine, and that's what I'm going to talk about. I'm actually going to, whoops, let's go back here. Oh, it worked. I'm going to talk about how to, or a process by which you as a group can, a suggested process to get hospital to support and to fund a perioperative medicine program. Because without that funding, it's going to be difficult. And, you know, over the years, anesthesia groups nationwide, it's been a slow embracing of perioperative medicine. And the common things we get, and I get locally where I work, is it doesn't pay, we lose money, our job is to run the ORs, not to do this stuff. And so it's a big roadblock. It's like, how do you overcome that when they're in these positions where they kind of control decisions that are made, is how do you overcome that? Well, in healthcare, the payment models are changing. I mean, they're becoming value-based very rapidly, certainly the government. So how does an anesthesia group look at the future? And I think it's very important for every anesthesia group to look at their value proposition and where are they to sustain their practice, because there is competition in that. What I want to do just moving forward here is just kind of briefly go back and look at the national healthcare expenditures. This is from 2023. It's 4.9 trillion. It wasn't that long ago, it was 3 trillion. That's a lot of money. And it's continuing to outpace inflation, as you can see. And it's increasingly a big percentage of the GDP. And so you look at hospitals, they account for 31%, physicians 20%. Surgical care accounts for about 51% of hospital admission expense. But on the positive side, it's a major revenue generator for hospital and accounts for about 65% of their operating margin. So that's a good thing. But when you go to the hospital and you want to start a program and you talk to the hospital about the program that you want to start and how obviously you're going to need some funding for it, it's important to consider their side of the story. What are their challenges that they have? And this is a list that's not complete. But this is the list you have, because when you go to them, they're going to say, we don't have any money. We're broke. We can't support it. And they don't really know that much about it, but they're busy and they don't really have time to figure it out. So these are some of the challenges they have. Rising costs of care for labor. Obviously, that's going up. Move to outpatient procedures. Big move to outpatient procedures. They have to report to for quality. And leapfrog ratings and CMS star ratings are also important that they want to achieve. Value-based payment models I just mentioned. Increasingly, there's more and more payment models that are based on value and outcomes, and they want to avoid CMS penalties for Medicare patients. And value-based purchasing, hospital readmission reduction program, hospital-acquired conditions, those are all very, very, if you don't attain what they need you to attain in order to get your money, it's a big loss. And then, of course, subsidies. I mean, all the anesthesia groups, basically 90% of anesthesia groups get subsidized throughout the country, and that's a big cost to them. And then, of course, maintaining profit margins. They have strategic goals, so it's good to learn about or to consider their strategic goals before you go to talk to them about the value proposition. And so within the perioperative services, and this is, again, not the full list, but their strategic goals are to improve patient outcomes, because they have to report what those are, to strengthen their preoperative process, implement ERAS pathways. Many of the hospital administrators, they've heard about it and they have seen some of the benefits. They definitely want surgical throughput. They want us to keep moving patients through the OR as fast as we can and get them discharged. Reduce hospital length of stay, readmissions, building a culture of multidisciplinary teamwork. I mean, that's what they want. It's very difficult sometimes for that to happen. And then HCAHPS, the patient assessment of how their experience was in the hospital. And then, obviously, to maintain financial sustainability. Anesthesia groups. What are our challenges as anesthesiologists? Well, we have falling payer reimbursements. Well, how do we make that up? Well, the hospital subsidizes this in many cases, so that's good. But as we transition to value-based payment models, what's the plan for that? At some point, we can't keep, we can ask for more subsidy support, but it may be difficult. Increased reliance, as I mentioned, on subsidies. Recruitment and retention of anesthesia providers. That's huge. I mean, just to recruit an anesthesiologist, they're competing in California for sure for providers. They're outbidding each other. Well, that's not sustainable either. So unless you keep up, you're going to have trouble. And then building a mutual partnership with hospitals is something that is very valuable to an anesthesia department and to the hospital. And so we share the same goals when it comes to that. And looking at new opportunities as an anesthesia group, we need to look at new opportunities. And I know groups are, but what comes to mind, obviously for me, is perioperative medicine. And keep in mind, it's a value-based care model. It does not pay for itself through billing and writing progress notes and seeing patients and all. It does not bill like that. It's not the way it's intended to do. It's a partnership strategically with the hospital, and it aligns with value-based payments that you're going to have. So perioperative medicine is an opportunity. It's been an opportunity for 15, 20 years, but it remains an opportunity. I think the door maybe a little, there's others moving into it if we don't move into it as a specialty. And thank goodness for the CP Med group and the hard work that they're doing and the meetings that we have and all that's been done, because it's been so helpful. If you look at the definition of perioperative medicine, it's a practice of patient-centered, multidisciplinary, and integrated or coordinated medical care from the time the surgeon says, I want to operate, till the time the patient leaves, and often 30 days afterwards, even 90. It stands to address all the elements of the triple aim, so that's the checkbox we like. Patient outcomes, money spent or cost, and then population health. It's aligned with CMS, value-based care. Definitely bridges the gap between clinical outcomes and financial performance, and it's tailor-made for clinical and operational success within the hospital. I mean, these are things it does, and it's important. Now, this is illustrates the perioperative care journey of a patient and coordination of it. Now, anesthesiologists touch the patient in many, if not the majority, of these touch points in this journey, but preoperatively in the front end is where a lot of the benefit happens in identifying patients, documenting their comorbidities accurately, which can then be reflected in DRG levels of categorization, optimization, referring them or managing them yourself with some of their comorbidities we already talked about today. And then enhanced recovery. I mean, we sit with the people, with the surgeons and other stakeholders in these enhanced recovery protocols that are built. And so that has obviously been shown to decrease practice variation, to lower length of stay, cost, and all those are good. And then getting the patient out of the hospital. But again, the discharge planning and the patient education can be done pre-op. I mean, we can tell when a patient's not going to go home just based on their risk stratification and some of the tools we have. Or there's a lot of other things we can predict, how long they're going to be in the hospital. So those are things that add value. Look at all the things. This is just a list of all the things an anesthesiologist and group can do, and many are doing most of these things, okay? Leadership, the time you spend doing that, directorships, hospital committees you spend. And these things, they're not reimbursed. They're non-clinical activity that we do because we care, which is great, and we want to help, but it's not reimbursed. So when the hospital talks about the cost of anesthesia services, they're not taking a lot of this into account. And the perioperative medicine, support and program incorporates some of these activities into that financial package that you would be negotiating with. Okay, let's look at return on investment, because as much as it is about patient care, it's also about funding and how do we make it work financially in a group. So I want to go through the things that I spent a lot of time doing. I know this is a table that's looks very complex as far as a short lecture here, but there's two ways to look at this: cost avoidance and revenue enhancement. So a perioperative medicine program, comprehensively, those are two things that it absolutely has shown to do, and the literature is clear on this. So looking at the categories in cost avoidance, lab tests, day of surgery cancellations, post-op complications, readmissions, length of stay reduction, unintended upgraded care, patient blood management programs, and then CMS penalties. Okay, so the rates that I have in this table I obtained from the literature. So I spent a lot of time pulling everything I could pull to get basic rates for what is the rate of a surgical operation, what's the rate of a post-op complication, and I had 14.5% for many articles. I mean, it ranges from 5 to 15, but generally 13 to 14%. What's the cost per event? So I put a number on that because that's in the literature from different places that have had that documented, $19,000. One thing that's really interesting is day of surgery cancellation. So if you have the day of surgery, patient canceled, with no follow-up patient ready to come in, like they're not in the hospital, you have to call them, you have to get them in there, the average time is 120 minutes. 90 to 120 minutes. That's time unused, nobody doing anything, the hospital paying money. So in an article now that's fairly old, it's like, I don't know, 2016, 17 out of surgery literature, $37 a minute. Well, you take 37 times 120 on that event, and then you figure out how many times you have that a year. Now I calculated, let's say 2 a week. Maybe that's too much, maybe that's not enough. Let's say 2 a week. That's 104 a year times what's $4,400, comes up to a big amount of money. I mean, that actually is money the hospital is spending money on and not getting any return. So without having a lot of time to go through the rest of these, the end number was based on my own institution's annual discharges of 4 service lines that I was asked to oversee from a perioperative care point of view context. So there was over 3,000 DCs, and if you apply the rates that I had to those, you would come up with the numbers I have. But the bottom line is, and we can say, are you serious? It's $33 million. That's money that the hospital's paying that we can help them decrease by doing that. And your institution may be different, and in fact, your institution's numbers are the best, but these categories are things you should look at in your institution if you can get the data. Revenue enhancement, another way. How do we increase revenue to the hospital by what we do? Because it really is revenue to the hospital, not just to the anesthesia department, for sure, because we're not going to make enough of that. Increased OR throughput. So if you do 2 more cases a week, 104 extra cases a year, $8,000 per case, that's a lot of money. If you can be a little more efficient, you can show that you were more efficient by what you were doing. Bed days saved, that's what we used in the program that I had, and I'll show you real soon, but by decreasing length of stay, we freed up beds. Those beds are now empty, can take a new surgery if that surgery is waiting to come in. And so that's a number that you can use, and then you look at what's the payment for a surgery to the hospital. And then inpatient perioperative consults, ambulatory pre-op consults. Very little money in that, but huge value to the hospital, okay? But it's not something you should ignore. It's about $140,000 or so. So that's something. Enhanced documentation. So just by enhancing your documentation, you can go from without complications in DRG rating to with complications or with major complications. And the facility fee to the hospital when you make that change is like 3 times what the base rate is. It's a lot of money, and also it's risk adjusted. So if you have sicker patients and you have a complication, it's going to be looked at in that context. Finally, before you go to the hospital, okay, you know what their challenges are, you know what our challenges are, you know what perioperative medicine can do from those 2 tables. Now you put together a pro forma. You look at the cost of a individual to be the provider in the perioperative surgical program that you have. You look at an APP, maybe a nurse navigator. You look at pathway development, data analytics, and you come up with a number. Now these are some of the numbers that I know are fairly accurate, but then there's some that, like the data analytics, I guess 50,000. It could be more than that, but a lot of money, right? The hospital's not going to want to pay that. But look at the cost avoidance and revenue enhancement. Like was already mentioned today, is the return on investment for every dollar that they put into this program. If you can achieve, and I know you can, what I've said, it's like $3 to $7. Every dollar they invest is that much of a return. Now they won't believe it, probably, but it's their own data if you can show. Now what we had, for a year I did this, and we partnered with urology. They were a willing partner. It's very important, a willing partner that works with you and lets you help them manage. And what we did with their urology patients is we reduced length of stay significantly. right? And so what we did is we saved beds, and we looked at the total bed days saved over that year with those particular surgeries, and it was almost 200. Well, if you take 197 bed days saved divided by the average length of stay for the new average length of stay for what we helped them with, you could potentially do quite a bit more surgery, which is a lot more revenue. So the other thing to look at is that graph. So we came in partner with them where they had these wide lengths of stay. Patients were in the hospital for 10 days, whatever. And we partnered with them and we decreased the variability in the length of stay. So now you can predict when you're going to contracts, and you're capitated and stuff, how long are they going to be in the hospital? By just partnering with them, we narrow the length of stay quite a bit so we could really predict the cost. So essential steps in securing perioperative medicine program. I cannot stress enough that anesthesia leadership has to be involved, and that is a big, big lift. But in a department that sees this in the future and understands the value added to this and that commits to it, that's a big, big step. Obtaining hospital operational data and analytics, very, very, very difficult. Very difficult. But they have to report this stuff to CMS. So a lot of this they should be able to get. And then you put this all together and you say, hey, can I help the hospital with this program? And in most hospitals, you definitely can. When you go to the hospital finally, you put all your data together, you've done your homework, you understand what the hospital's needs are, their strategies, you've costed this out based on the hospital data. Now you go and you put the presentation, the value proposition into 4 basic buckets, okay? Things that they understand, and you don't start with money. You start with, not that money's important for sure, but it's with patient outcomes and patient benefits. You start with clinical outcomes and safety. You go into operational efficiency, financial impact, which we've gone over, and the patient experience. This is what you talk about with them. And you have the data with you. You have to have the data with you. You can't go in and just be a concept, in my opinion. I think you have to have the data. And then, looking ahead, what's the future direction of what we've been talking about here? And it's building coalitions. Not staying so siloed in the operating, coming in, disappearing at night and stuff. I mean, I did private practice, and I wanted to get out of there too, but I'm not saying you do, but I did. I wanted to get out. So it's like partnerships with people and building these professional relationships, and including with the hospital. Perioperative medicine is a learning health system program. You capture the data, you retool, you revise, you figure out how to do better, how to lower costs through better efficiency and things like that. So it's a learning system, and then it's also good for population health, which is a big thing for hospitals and their strategies. And then, of course, payment. So in closing, roadmap for incorporating this into an anesthesia practice. And these recommendations come from my own experience because I'm still learning. I've had so many roadblocks and headwinds that I've learned over the years. So basically, you have to create a multidisciplinary team. Choose your stakeholders, bring them together with the program that you want to create or that you want to broaden. Bring them together. Ensure that there's significant involvement by you in preoperative care. I know that probably most of you in your practices, but many don't have any significant input into the preoperative phase. That is absolutely, in my opinion, very, very important. Partner with the surgeons to develop ERAS protocols. They need a partner. Most of the things in the ERAS are anesthesia anyway. Partner with them. That's going to take some time, but there's going to be some benefits to that. Start with 1 or 2 surgical service lines, okay? I had a little bit of I made a mistake because I was too naive. I said, yeah, well, let's do 4 of them, and that's not right. So do 1 or 2 and develop that relationship, put these programs in place. Obviously follow OR efficiency, cancellation rates, and throughput and all that. Create an acute pain service if you can, Organize the effort as a QI project. And then you're going to have data. It's very, very difficult, I will tell you, but it can be done. It's not easy. And you're not alone if you can't do it. Most of the programs that I've talked to can't get, data very easily, but you need to get the data. And then network with the different stakeholders, continue to network, continue to talk to them, and then don't give up. It's so easy to give up. I shouldn't say give up. It's so easy to get discouraged and to put it on hold. It's so helpful to the hospital, and I think you can make the case. And these are just some references that I had that I think are very, very high value. All right, thank you. Did you want me to stay? Yes. I guess I went over.
Thank you, Gary. We have some time for questions, so if you want to ask a question, please go to the mic. We do have some, tell me where you are, where you're from, and ask a question.
Yeah, I'm Charles Plant. I'm from Mobile, Alabama. My question is about accountability. So I reviewed a case earlier this week, and it was a case of patient harm that was preventable. So how do you build in accountability in this perioperative system?
Gary, you want to take?
Yeah, nobody's perfect, and we have things that occur certainly in our institution too. So I think being on the committees, talking to hospital and the quality people, and investigating and doing all the things we do, being very invested in it is, I mean, that sounds really simple, but I mean, maybe you want a more complicated answer, but that relationship is so important, and caring and, and educating and trying to figure out root cause, what happened, and changing that framework. How did that person in that condition or that position, how did that happen? And then, I mean, there is accountability too, so, but that's what I do. We talk to quality a lot.
I think I would agree that building that relationship
is huge.
Is key, and often that go with accountability, and then you do have to hold each other accountable.
You do.
A question? Yes.
Yes, hi, Garrett Weber. I'm at Westchester Medical Center, and I run our preoperative clinics and also anesthesiologist. My question is about the education in perioperative medicine. There's a lot of discussion about fellowships, but what about even further upstream? I haven't seen anything about medical school, and for if there's any, for those of us that mentor medical students into anesthesiology, is the ASA pushing out any, products or any sort of resources, for early on in residency, but even beforehand, for medical students who, even possibly as part of the LCME and, for education core competencies?
Yeah.
It's a great question, and you are way ahead in the future. Maybe I'll let Dr. Ehrman tackle that.
Yeah, I mean, there's definitely been conversations about, I mean, I like your idea of sort of looking at it upstream and kind of engaging med students early on. And, I think it starts with looking at the current curricula, med school curricula. I mean, a lot of it is pretty standardized, like LCME has certain requirements. When I did a fellowship in medical education back then, and that's what we did. We looked at the entire 4 years of, it was really, the focus was pharmacology, trying to really figure out what are we teaching, how do we, doing it in a way that is all makes sense. And so I think part of it would be, I think it would be a great project, I think, for CP Med, is to kind of look at current state of medical education, because a lot of it's pretty standardized, unlike perioperative medicine fellowships, and to see where there are opportunities to apply some of the principles that we discussed today. And I think that would be great. And certainly, the same thing goes for our residents as well, right? So we're not just, I mean, we're talking about perioperative medicine fellowships, but at the same time, lots of opportunities, both upstream residents as well as downstream, things like MOCA, and that's something that one of the subcommittees is working on, is to, add more of those concepts into MOCA. So yes, really pretty wide range of, customers, if you will, and lots of opportunity. But that's a great question. I mean, Tijay, I don't know if...
Yeah, I think if anything, that would just open up to the medical student about anesthesiology as a specialty, because often, in the early days of medical student, anesthesiology doesn't even come into their vocabulary, right? And until when you're starting to choose specialty, and suddenly you think, okay, which one I'm going to do? But if you can introduce that earlier on, and now, especially with the integrated curriculum, even year 1, year 2, they're starting to do, rather than just basic science, they're starting to do into clinics.
And I think, students are surprised to see that we have a role outside of the operating room. And I think, I think it would open up.
All of the thing. And I would say anesthesia, med student anesthesia rotations, right? They're third year and fourth year electives. That's another opportunity where it would be even more focused on, students who are actually in the, doing, participating in anesthesia activities, and certainly fourth year students, right, who allegedly are very interested in going to anesthesia. So lots of opportunity, I think, on all of those levels, I think, to maybe looking at med student anesthesia rotation curriculum would be another opportunity, yeah.
Thank you for the question. Any other questions? I have on my watch exactly 5 o'clock, miraculously. I want to thank you for all of you who